Hmm.
Like that last one?
Yeah.
Sorry, I should have asked you sooner.
Good morning, Sunny.
Hey, mate, how are you? I sent some couple cases if you wanna
Yeah,
talk about them, or you can talk about other things, whatever. But
yeah. Did you send it to?
your email,
Okay, let me go check it out.
couple cases with the flat back syndrome. So
Yeah, and as well, I wanted to have with Dr. Raouf. Now, you and I, we can work with Dr. Raouf, so show him our indication when he starts seeing patient for us. It's important for him to know our protocols for patient selection and so on. I think that would be a good situation to usher him into our. He doesn't have the credential yet, but soon he will.
when is he gonna get a Texas license?
That's a good question for Ross.
Hmm. How was your Crookston up there?
Very good, very
Oh,
good.
good, pretty efficient.
Yeah, we got 8 cases. We got them by 320,
Good.
but most of that was sacroiliac joint. They were really sweet cases.
Mm-hmm.
Okay, I'm getting the
So
thing.
you're doing okay without a PA help, like writing orders and all that stuff?
I'm not okay with that, but what choice do I have?
What a choice.
No, no, not
I've
only
been, I've been
that.
entering the pre-op orders before you even started the case, post-op orders.
Yeah, well, the thing is, we don't get help there. That's it. We don't get help, and
Mm.
all my patient went home. Well, 5 of the patient went home same day. 2 of the patient I sent home next day. One
Mm.
patient stayed 2 night, the 4 level,
Mm.
and then I'm doing surgery in Alexandria. They're calling me, put the orders
Orders
in,
in.
and
Yeah, I know.
are you kidding me? You know?
Actually, I got a call. I got a call from I was doing something else Friday and I got called that patient cannot tolerate oxycodone. I got to give a hydrocodone instead.
Mm-hmm.
So I didn't have a computer, so I used the iPhone and the remote Chrome desktop. And it's hard to do with the iPhone. Prescribe, because I was doing a remote Chrome operating another computer from
Yeah.
my iPhone.
Well, we are not going to. We are not going to. I'm not going to keep doing this without help. But it's not only that it's not just inconvenient. If
Hmm.
we don't get help,
Hmm.
and then literally we cannot prioritize what really matters to
Others,
other
yeah.
stuff. And then this is like a recipe for this is a setup, this is a minefield when we are so overloaded with paperwork and unnecessary work that we
Mhm.
cannot literally pay attention to what really matters.
Right,
And
right.
then when
Right.
something matters,
Mhm.
guess who is going to be taking the
We're gonna
taking the
get the
blame?
flag. Yeah, we're gonna get the flag. Yeah.
Yeah, yeah. So, so I have for some reason, Sunny, I'm here.
You don't see it? I think I sent the images email.
Well, I don't see it.
You don't see it?
Which one? Which email did you send it to? Oh, I see it now. Okay, got it. Got it.
Yeah, I got it.
Okay. So let me just,
Just one email. One email.
yeah,
With some
yeah, I see
attachment,
now.
so you can see that. But
Okay, so let me,
who else is here? We have a Dr. The
Dr. Steiner just joined us, and Dr. Rauf, I want him to join us because I need him to be familiar with our protocols and so on.
Oh,
So,
by the way, I did submit two abstracts for the Korean Orthopedic Association. So they're
hi,
gonna let
Scott.
us know by May.
Hi, how's it going?
So good. How are you, Scott?
Good.
Okay, so Sunny, I have your picture. Here we go. Let me just share the screen with us. Okay.
Scott is here. Why don't you put in that one? Yeah, that was the stimulator. That's good. Yeah, that's one patient. I just saw her 3 months after the surgery, so she's got a lot going on. So show that.
Give me
And
one
this
second.
is, yeah, that's an 80-year-old came to see me with picture like that. You see that she's got a spinal cord stimulator and also had a SI joint fusion. That was done in St. Cloud. I think they did it in Central Care, St. Cloud Orthopedics.
Okay.
And she had a multiple, I think 3 or 4 back surgery by Linley in Alexandria. She's from Alexandria, you know what I mean? So she had a multiple surgeries, and she came to see me about 6 months ago, kind of like that, pretty much disabled, kind of all bent forward.
Okay.
In fact, she was walking like a chimpanzee, all bent over. You can see that's a standing. I think that's a standing film, and you can see how she's really levered over there, right?
Yeah. Yeah. Well,
Okay.
yeah. Go ahead. Go ahead. First, describe what we understand these days on the flat back syndrome, because I don't believe that's a term that necessarily everybody knows what it is.
Flat back syndrome is when you drop a plumb line from your C2, middle of your head. The plumb line should go through the hip joint. Okay. As you can see in this case, the plumb line is like 2 feet in front of the hip joint. Okay. Human beings we are bipeds, not quadrupeds. We're supposed to, upright position. There's some progression. You go into some kyphosis as you age, but not like 2 feet.
A little background to that. Obviously, as Sunny was saying, because we stand up, our spine has certain curvature, and more or less, our body is truly optimized to work within the confine of those curvatures, certain limits.
It's a like zone of efficiency. There's a cone of efficiency. In that cone, we are not exerting too much energy to stand upright position.
As a
But
matter of
if
fact,
you get out of that cone of efficiency,
mhm.
then it becomes it's very, very difficult to maintain upright posture. Okay.
And as a matter of fact, it is good amount of the research studies and so on done regarding that for mile, human is the most efficient animal to walk. We spend least amount of energy to walk
In upright
because
position,
in
right?
obviously in upright position, and
Mhm.
like they have done across the animal world and so on, like chimp they do this knuckle walk and so on, but human, we can outwalk any animal. We are not fast, we are not strong, we are not there are lots of things we are not, but we are the most efficient walking machine. Literally there used to be a way to walk other animal to death, like the hunt to hunt them that way and so on. It's, okay. It seems that Dr. Rauf has problem getting, and let me just send him. Um,
So in history, this is a Scott 80-year-old woman who came to see me 6 months ago for the first time, completely disabled, basically in a wheelchair, unable to stand upright position. And we got a lot to learn from this case. That's why I'm presenting this. And but otherwise, she was in good health. She might be 80, but no heart disease. She doesn't smoke. She doesn't drink. Basically, doesn't take any medication, maybe occasional Tylenol, not blood thinners, no stroke. So we got to look at not just the chronological age, but what kind of condition are these people in? I
We
mean,
call
she
that
was,
physiologic age,
yeah.
When I
She was
was
like ASA even almost one, despite her age. Her age throws into ASA two, the anesthesia risk scale. But I mean,
when I
this
was in the
lady
med
had
school,
all the surgeries without any difficulties, no infection, nothing like that. So she came to see me with spinal cord stimulator. You can see she had a SI joint fusion, and she had like 3 lumbar fusions. And each time she had the procedure done, she never gets better and just gets worse and worse.
when I
Okay,
was in the med
so that
school, the
was
elderly was defined 70 years old. Now is defined 75 years old. It used to be an independent factor of indication setting and lots of other things. But now we have a good indication and we have enough medical understanding and knowledge that age by itself, the number alone, is not the independent factors. What we call physiological age, like what the status, how healthy. A 40-year-old person with lots of other comorbidity might be not a candidate for surgery, whereas 85-year-old person who's otherwise in good condition is. And I think that transition happened about 10, 15 years ago, that we now we literally abandoned the idea that just the number itself make indication for surgery or not. Like 20 years ago, when a one-level fusion in my residency was a 7-hour surgery, and in some places still is, you would never offer an elderly a fusion. So I think that has really changed in the last 15 years. So, Sunny, what are the symptoms of this patient?
Yeah, sorry, and just to add to that, in the 15 years, they started introducing the fragility score, and that I think has surpassed the age completely, like the stand-up to go test, etc., because that was correlated with, higher fragility score was correlated with.
Can you describe that? That's actually in NeuroPro, in our database. That's one of the things that we are able to factor in and gather that information. Dr. Arya, can you describe that fragility index in a little more detail to us?
So it's an index. It's from 0 to 100, and I whenever I get them, I usually do it with a physical therapist. But there are a couple of tests that they do. One is like a physical test where it's called the stand-up time to go TUG test. They stand up and how long it takes for them to stand up from a chair, walk, I think about 20 yards, turn around and come back. Then another one is cognitive impairments, their hemoglobin, then their albumin in terms of nutrition. And then based on those numbers, they have a score from, I think, 0 to 100. And then that score itself is very well correlated in the literature with adverse outcomes, not age, but fragility.
So, well, I see Dr. Rauf is with us, and I want to emphasize here that these are important factors. And to be understanding it better, I'm going to show it to you. But Dr. Arya, describe to me what is the difference between the fragility index and Karnofsky index? Because, are you familiar with Karnofsky index?
I never heard of it. What is the
Okay, well,
Karnofsky?
Karnofsky index is literally a modification. It existed long before fragility index. It is practically a fragility index regarding cancer treatment. The cancer, they had it for a long time. Who do we treat? How much resources do we put on a patient? And who is the right person to benefit from that? And Karnofsky index was created in the cancer treatment to understand same thing that we are dealing now 30 years later. So Karnofsky index is like 30 years older than fragility index. So I want to show you on our initial visit here. So, do you have any other name for fragility index, Dr. Ayat? There is a test that is more, there are obviously many tests, but there is one that is more established than the other one. Do you know which one I'm talking about?
The one I rely on the most is the time up to go test. But
The
I
one
don't.
in NeuroPro, we captured the so-called Charlson comorbidity test or index. And I'm going to go through the things that are there. Now, obviously, the actual age is part of Charlson comorbidity index, but that's just one of them. History of MI, CHF, PVD, peripheral vascular disease, CVA, cerebrovascular disease, TIA, history of TIA, dementia, COPD, connective tissue disorder, peptide ulcer disease, liver disease, diabetes, hemiplegia, and so on, history of solid tumor, and so on, history of leukemia, lymphoma, history of AIDS. You see that there, it brings factors to the game that says, and I just count for you over 10 things. Age was one of them. So age as well itself is a factor, but not an independent factor. So this is the so-called the Charlson comorbidity test, one of the main. Obviously, there are some other tests, but this is one of the mostly accepted so-called fragility index. And by the way, Dr. Rauf, that if you go to our NeuroPro, where it says patient, the fourth tab says initial visit is where that is captured. So you should be familiar with that. So the so-called fragility index and Charlson comorbidity index are interchangeable in this sense.
Yes.
And they're very well as well, modeled, not the same questions, not the same, criteria, but they're modeled like a Karnofsky index. In our inspired spine multidimensional protocol, we use Karnofsky index still. But I'm hoping that in one of our next visit, Dr. Rauf, we should think about that, replacing it with our the Karnofsky index with the Charlson comorbidity test and index number. And the numbers are as well 0 to 100. And the test is very well is established and validated. So
It is the same like a Karnofsky score, like that patient can move the 100 score, we can give like them, or it's a different score for that test.
the scores are within the text. Now it's still 10 criteria. And then each of them get the 1 to 10, and then the combination makes it 100 point. And high number is bad, low number is, I'm sorry, in the Karnofsky, high number is good, low number is bad.
Yes.
Okay.
Yes, sir.
So, and it should be on Google Drive available to you, our so-called multidimensional protocol. So here is, I'm not sure if this is the most recent one or not, but let me open it up. So you have to be familiar with it because we are going to literally use it for many of, so this is not the latest version, because in the latest version, we combine the upper two in one, but here you see functional test. And then overall status here, Karnofsky. And if you go to let me go to the other thing, that one of them explain exactly. Yeah, that's the most recent one. Let me make it bigger. So here you see the Karnofsky, and then in the next few slides, you see the interpretation of those numbers. I think based on all the information we have, we can now replace Karnofsky now with the Charlson comorbidity index. So please put it on our agenda to discuss it, and set up that maybe toward the summer we should revise, update our inspired spine multidimensional protocols. Okay, let's go back to Sunny's case, because I think that sort of is an elderly patient, but a functional patient. The main problem of this patient is pain and problem with ambulation. Is that correct, Sunny?
That's correct.
Okay, now generally, I mean, what are the options in a situation like that? Sunny, I mean,
Well, she told me that she'd rather die and keep on living like this. She
mhm.
doesn't feel like that this is something not worth continuing to live in this condition.
And the patient tell you
People are
that,
very
yeah,
disabled. These are very, very disabled.
yeah.
They will take any kind of risk, even a small chance of recovery from surgery will fix. And her last surgery was spinal cord stimulator. And
Mhm.
Scott, you were here, and spinal cord stimulator, and she got worse after that because that was the wrong thing to do. I mean, you got a flat back syndrome, you don't want to stick a spinal cord stimulator in there because this is a mechanical problem.
Yeah.
You know what I mean? It's like you got a hip fracture, you got a severe hip pain, you stick a spinal cord stimulator rather than fixing a hip.
Yeah, yeah.
So a spinal cord stimulator usually, in my experience, doesn't work well for a mechanical problem.
I tell
It works for-
patients it can work for some low intensity mechanical pain, but how long ago did she place the stimulator?
She had it in about a year when
Yeah.
she came to see
Year
me,
to
but, yeah.
A year to 2 years. Oftentimes people will do they'll do okay in the trial. And I think the stimulators can help with mechanical pain. This is anecdotal in my observation, trying to make sense of why a patient would do well in a trial, but then a year or two later say they don't. But as what I surmise is that as the patient ages, the spine continues to degenerate, and the mechanical pain overpowers the stimulator's ability to address it. And so,
Well, I think we should as well consider what the stimulation device really do. It goes to the posterior column and prevents the pain signal to pass through.
and also engages the pain inhibition pathways.
Yes, but
And
what
can
Usually
address
not
some
good for the
suffering.
back pain. It's usually good for the leg pain.
Yeah,
Yeah.
although the newer waveforms, ironically, have been shown to be more helpful for back
too.
pain.
Okay.
Yeah.
yeah,
But I mean, but over time, it's either tolerance but I think it's just the spine continues to degenerate. Seems to always work very well for neuropathic pain, burning, tingling, numbness.
Right. We know that. That's
And
well
sometimes helps with achy pain in patients.
Mhm.
But I think what happens is just it works for a while for the mechanical pain, but the spine continues to degenerate, and that mechanical pain just overpowers its
But the
ability.
interesting is this lady's fine when she lies down. Pain goes away.
Sure, yeah. So it's
So,
purely
in a
it's all
supine
mechanical.
position, you don't have a you don't have a flat back. You don't have to stand, but she just cannot go on her activities. She cannot stand to do activities. She's all bent over. So that's the
the
problem.
way I describe it to my patient is that pain is not the fire. Pain is the noise of a smoke alarm, that there is a fire. Sometimes the smoke alarm itself is damaged, meaning the pain apparatus, what we call neuropathic pain. That's what it is. And then, obviously, stimulation device is very effective for that. We know that. Now, when you have a mechanical, as you have described, Scott, the mechanical pain, in that case, the problem is the mobile L4-5 spondylolisthesis that pushes on the nerve with the motion. And there's only so much you can suppress that kind of.
Yeah.
And that is what stimulation device is. Stimulation device is like a little person you hire there, and every few milliseconds it pushes the reset button on the smoke alarm, so you don't hear the noise of the smoke alarm, but it doesn't fix actually the fire behind that, if there is one. Now, if there is no fire, it's just a faulty smoke alarm, which is what we call neuropathic pain. That's a perfect solution. Now, but for a long time, I know you and David have been as well, been using it for a long time. Is that for a long time the surgery, putting the fire out, was a deadly surgery. Like, who want to do a 4-level fusion for an 85-year-old person with lots of comorbidity? The infection rate, the complication rate is so high that even if we are just suppressing the pain, treating the pain symptomatically, more or less, that's a realistic option we got. But I think that at least with what Sonia and I we are doing, we are changing that equation, that we can truly go and fix the problem. So, Sonia, you want to continue how you proceeded with this?
Yeah, so I'm curious what you think the mechanical pain generators that can be addressed. That's what, because I look at this patient, I don't know what else.
Well, do you see
Yeah.
that L5S1? There's a spondylolisthesis there.
Oh, and it's not
the
fused there.
flat back-
Yeah. Yeah, it's
and
like
what?
a grade 1. Did it move in flexion
No, I would
extension?
call it bordering grade 2 actually. And as well, Sonny just described to us that flat back syndrome where it's really the cone of economic is really out of whack in this patient. That what that means is that the muscle they really have to well, Scott, what imagine there's a weekend, you go and do yard work and you do overdo it. The next week, all your muscle in your body going to kill you.
I can describe this to like an automobile, the wheels out of alignment. I had like ice built up my rim, and I could not drive more than 50 miles an hour because the whole thing was shaking like crazy. So I had to stop and chisel out the ice, and I was able to drive. That type of thing, you know. It's
Yeah,
just
so
it's like
this
a
is
mechanical thing here.
yes. So Sonny, go ahead.
Yeah, so unfortunately, the spinal cord stimulator was placed open fashion. They
Mhm.
did a thoracic laminectomy, put that in.
Oh,
Okay.
it's a
You-
paddle.
Yeah, it was pedal, so it was really a hassle for me to take it out. I mean, surgery as it is very difficult.
Yeah.
So I pulled it out, and then that took me like 20 minutes wasted, you know. Then I did the surgery, and this was like an 8-hour surgery. No, not that one. That's not post-op. Keep on going. That's another patient. Let's see not that one. Keep on going. So this was the surgery. I had to open it up like that. The next one, I had to do the massive surgery. Do you see those? Yeah, next one. Yeah, so this is the post-op. You see the staples there? Look at the staples. I had to go all the way up to the T5 through S1, and you can see now I was able to dial in that lordosis. You see the spine is not going forward,
Yeah.
and so I was able to get a good correction. But that surgery had, it was like 7, 8 hour surgery with
Mhm.
about 500 cc blood loss and things like that. And show the next X-ray, Hamid.
So did you remove the other hardware?
Yeah, I removed the other. Do you see this is AP view? Do you see that SI joint fusion? Because when you do I had to break the L4, shed all the solid fusion. I had to chisel through the L4 fusion and crack the L4 body. And I could not put the iliac screw on the other side because you got the SI joint fusion there. It's hard to put that big screw because you need that big screw in the iliac screw because such a long lever arm. Otherwise, everything's going to pull out. So I put her in a back brace, TLSO, and show the lateral again, the before previous X-ray.
Yeah.
So she did well, except she woke up with quadriceps palsy on the left side. Her left quad was like a 1 out of 5 after the surgery. The reason being, when you bend these people, when you do the PSO, pedicle subtraction osteotomy, I mean, I resect everything, but sometimes there's a stretch on the nerve root, okay?
Mhm.
Because it's like a bend forward and sometimes the nerve get pinched. So I had a quad palsy on this lady. So she ended up, after she stayed in the hospital about 3 days. Believe it or not, I think we lost 500 cc's and she might have gotten 1 unit of blood. And I sent her down to a nursing home in Alexandria, and she stayed there about 2 weeks. And I just saw her back 5 days ago, this past week. And I'm not concerned about this is another point we should talk about. When there's a paralysis of a quadriceps, I never had a single patient, it never recovered. They always recover because it's mediated by multiple nerve roots.
And yeah, very important fact.
Yeah,
Yes,
yeah.
under
Quad palsy, I'm not concerned. I'm
quad-
concerned about foot drop, but quad palsy, they always come back.
Okay, well, let's ask Dr. Aya and Dr. Rauf. Dr. Aya, let's start with you. Why, one of the things about the quad, Dr. Kim mentioned, why is it the quad and tibial anterior are so different in nature? Maybe Dr.
So the quad, I believe, gets 3 and 4 nerve roots, and then some people, there's some variation where they might get a little bit of L2 and 5. The tib and gets mostly L4, and then sometimes it can get a little bit of L5. So there's just a lot more. There's just a lot more nerve pathways to the quad than there are to the tib and.
Well, that is definitely a very important factor, that there are so many segments involved in the quad. What that means is when one segment is out, the other, number one, those nerves that goes to the muscle sometimes reorganize, cover the other nerve, but as well, those muscle fiber, they become stronger and compensate for the lack of, as a matter of fact, these both factors play a role, that literally initially, you lose like one of the nerve roots completely. Then you lose like 25% of the strength, but so your quad become 25% weaker. But then within weeks, literally, the other muscle groups that are still innervated, they become stronger, compensate for that. But as well, the reorganization that the other muscle get more innervation from, there's some fluidity there, plasticity there, that they get as well, innervation from the other. There's another factor that's very important, and that I'm not talking about the mass. Obviously, tibialis anterior is much smaller muscle and than quadriceps. There's another factor. Dr. Rauf, do you know what other factor plays a role makes the difference between quad and tibialis anterior?
Is it the distance that the nerve has to go?
Yes,
So
it
it will
is.
heal faster. Yeah.
Yes, it is, Aya. You jumped in, but yes, it is. Now, nerves, imagine you damage the nerve at the nerve root level, at the spine. Nerve, as long as you haven't completely transected that, there is a natural healing process, and that natural healing process is how fast do our nerves heal, Aya?
I believe 1 millimeter a day or something.
Yes, 1 millimeter a day or 1 inch a month, about. Okay, so imagine if they have to grow this long, like the 8 to 10 inch, to reach the quadriceps, versus they have to go twice that amount to reach the tibialis anterior. Okay, by the time the nerve reached the tibialis anterior has been so inactivated that there is really nothing to recover. It takes 6 months to 8 months. But in that time frame, because of inactivity, tibialis anterior literally turns into an inert kind of scar tissue, because every muscle reacts the same. If you take the innervation away, the muscle dies. So in that time frame that it takes from our back to reach the tibialis anterior, there's not much to recover from the tibialis anterior. So prognosis of tibialis anterior foot drop is much worse than tibialis anterior. So yeah, your observation is backed by lots of research and science, Sunny. So you want to
I
continue?
never had I've had lots of quad palsies. I must have had about 50 quad palsies throughout my career of spanning 37 years. And
Yeah.
every single one of them came back. Okay.
Yes.
But not the foot drop. I had many, just for the reasons you mentioned. Many foot drops I've had. I think I've had about five up to 10 permanent foot drops in my career. And prognosis is very poor with the foot drops. Okay. So that's.
But it makes as well different, especially after OLIF. Sometimes we see that. Number one, there are few things, especially I think for Dr. Rauf, is very important to understand.
Yes.
We have done extensive research on that. Even though we consent the patient for 15% risk of nerve root irritation, that actual risk is about 8.2%, and it's mostly L5S1 because of the anatomical consideration.
Trying
Meaning
to
that
get in the camera.
for
Yeah.
L5S1, because of the ala, because of the
Mhm.
iliac crest,
Yes.
because of the
Mhm.
anatomy, this is the most prime place that we get nerve root irritation. We consent the patient for 15%, or 15% if 5S1 involved, 10% if 5S1 is not involved. After the learning curve, that actual risk is about 8%. My risk right now is under 6%. And they have a very good prognosis. Most of that comes because we have to push the nerve to the side. If we didn't really do the neurotodemesis, we cause just pressure on the nerve. And then usually they prognose very well, very good, because after a month or two, actually nerves come back to life.
Yes, sir.
It doesn't have to grow all the way to the muscle. It just have to wake up from that initial pressure.
Yes, sir.
Now, what is important that we compare that to open traditional surgery and see that one of the things is with the OLEF is patient is ready to go home next day. What that means is he's standing up, ready to go home next day, and is smiling, pain is gone, but tells you that, but what's wrong with my left foot? It's numb. On top of the foot, it's numb.
Yes,
Okay, not all of that is a complete. And it's very important if it's a complete versus non-complete. Even if there is like a little motion in L5 in the tibialis anterior, that indicate that it's not it is a very good prognosis if there is even a little function left there. So next day after the surgery, we come there, or day of the surgery, as a matter of fact, the tibialis anterior is weak, patient foot is numb, but is not complete. They have a very good prognosis. As a matter of fact, in our study, only one patient in 303 patients had permanent damage from the surgery itself. That makes that risk 0.3%. So Dr. Aya or Dr. Rauf, what is in a TLIF in comparison, what is a 1-year result of permanent nerve injury after TLIF or PLIF?
I have not read this research. I will work on it and tell you that about. But
So Dr. Aya, what do you think about that?
tibialis anterior is a small muscle. When the L5 nerve is injured, it is very tight between L5 and so it's mostly due to tightness and long root of the nerve and small size of muscle make him more susceptible to injury and recovery. Like
Well,
quadriceps have a long muscle and big muscles, and he has the 3 nerve roots over there for supply. When patient get exercise and it get better.
no, well, my question is very simple.
Yeah.
Literature has reported what the rate of permanent nerve injury after a year. They always mention a year. Nobody mentions the early result because the early result is horrendous. But 1-year result of permanent nerve injury after PLIF and TLIF. Dr. Aya, do you know what that number is? Literature.
I think it's about 3 to 11% permanent.
Well, if you get uncomplicated cases like a regular PLIF TLIF, it's somewhere between, in a very small studies, it has reported 1%, but most of the studies say it's 3%. In multi-level, yes, it can go up to much higher if you have complex cases, Scoli cases, and so on and so forth. So I'm talking about in our study, one patient had permanent damage. In a regular surgery, it's almost 10 times more. In complex cases, it is a lot even higher than that. But our study didn't separate simple and complex cases, it included everything. So by all regards, even OLEF has a better result regarding the permanent nerve injury after a year. Now, initially, where nobody reports, that rate is 10 to 15%. We consent the patient. In reality, is about 8.2%. But most of them get better literally after a month or two. And you see that they come a week after the surgery, they have a little foot drop, they have a numbness there, and then, but you check them 2-3 months later, it's all completely recovered. Now, And other people who do transcabin approach have reported as well similar result. But I guess, Sunny, I think our result is much better than any other result I have seen out there. And we checked them, we gathered the data. We are not using gut feeling here. We have
One thing I'm really happy about Olive compared to TILIF, that we have no complication. Is that we never had out of our 3,000 plus cases, we never had a CSF leak.
Yeah.
TILIF, you get I would say CSF leak, especially previous decompression. I was
Don't say the number. Don't say
up
the
to
number.
5%.
Oh no, Jesus! Don't say the number. I want the young people, they comment on that. Literature reported up to 7.8% average CSF leak
Which is
durotomy.
a headache for the surgeon as well as for the patient.
Yeah.
They get a
Now,
spinal headache, and surgeon gets headache too.
well, in Olive, we are extraforaminal. What that means, it makes sense we don't have CSF leak because we are not supposed to be where the dura is. We are outside of it. So that is why we have very little reason even to expect the durotomy. So let's come back to this case though, Sunny. So a patient 3 days and then went to the rehab, and in what
So
time?
I have a 3-month follow-up. I just said I saw her last week. That's why this case came up. Pre-op, her pain was 10 out of 10, 15 out of 10. Okay. Now a pain diagram shows her pain is 0 out of 10.
Mm-hmm.
She's got only complaint is her left leg is a little weak. I mean, it was about 4 out of 5, but it's improving every day. And you never have a surgery that goes from this is a real surgery. It's like a hip fracture surgery. You go from 10 out of 10 pain with 8 previous, this would be like failed back surgery syndrome. Okay. Rather than condemning her to live a life like that, we are able to convert that to 0 out of 10 type of after 3-month follow-up. Okay.
So Sunny, do you want to
Only
comment
thing
on
is
that?
that it requires a huge surgery and technical expertise, to accomplish this. But that's why insurance companies are approving this type of surgery because it's a real surgery. It's just not like we're not just doing it just to make the X-ray look pretty. Okay, this has a real live impact on the patient. That's all I wanna say.
Sonny, do you want to comment on the so-called iliac crest screws?
Yeah, that's a S2 iliac screw because I have to break the L4. You need a lot of fixation above and below. You got to grab the long construct, to maintain that alignment. So S1 screw, I put a bilateral S1 screw, but you see that left side, you have that big long screw. That's like 90 millimeter by 8.5 millimeter. That is the biggest, longest, thickest screw you can insert in a human body. No screw is bigger than that. Even hip surgeons, pelvic surgeons cannot. That's the longest screw you can insert in a human body. And you need that kind of fixation. That goes through the sacrum, across the SI joint into the ilium. You need that long screw. Show the lateral, Hamid. Because I broke it. See how the tip of that long screw is? That is way in front of that. That give you a fulcrum so the patient doesn't pull that screw out and go forward again. Okay, so that's a critical screw. Without that, they used to have lots of failures without that screw. I was nervous because I was able to put that screw only on one side.
Because of the sacroiliac joint fusion.
Yeah, that's a S2 iliac screw. So in order to I was nervous because I wasn't able to put only on one side, so I put in a $5,000 custom TLSO and have her wear it around the clock all the time for 3 months. Okay, only take it off for showers only. TLSO number 6. That's not like cheap off-the-shelf brace. That's a brace that This is another case I did the day later, and you can see bilateral iliac screw. But I couldn't do that on that lady because that's only one-sided. Just that SI joint.
Now, Dr. Rauf, you will learn it from Dr. Kim. Dr. Kim does a little different iliac screws than I do. He does the S2 through the S2, practically tricortical screws, correct?
It's a tricortical, yes, that's
Yeah.
correct.
And that's a very neat technique. Because I don't do
No
this kind of-
connectors. There's no connectors between the rod. There's only one rod. There are two rods, the whole thing. This is another case, but
yeah.
it's another ADO, and he did well too, but he didn't have any neuro deficit. But the other lady had a neuro deficit.
So the way I do it differently is that I go just actual iliac crest and then put a almost 60-degree bend on the rod and then go directly to the iliac crest. But soon we have something much better. We have so-called iliac bolt that we have measured to be 2.5 times stronger than any iliac screws. And then if you talk to Mitch, he will show you the prototype. Hopefully within a few months, we will have that so-called iliac bolt. And the advantage of iliac bolt is it can be all performed MIS. You don't need to open it. And takes literally 3 minutes to put it in. And then you have a compression on the iliac crest that provide 2.5 times stronger mechanical stability than iliac screw itself. So, but you may want to talk to Mitch Ruston. Mitch, are you here?
You know it, Dr. Abbasi.
Okay, so when is our iliac crest going to be available commercially?
This summer, summer 26.
Okay, so a few months. Okay, so
How about Dr. Rauf? What kind of fixation does he use for pelvis? Do you go down to the pelvis often for the
No,
long
we
construct?
are doing any pelvic fixation over there. So we just only fix we did not perform any iliac screw over there in our institute where I was working.
Got it.
Yeah.
okay, well, we will have a lot of
Random-
opportunity for that. Yeah, go
Random
ahead.
question, Dr. Abbasi, but with the MIS option, do you see yourself being able to do it on an outpatient setting, or do you still
Oh,
think
absolutely. Absolutely. That's the
national
idea.
team? Oh.
That's the idea. Mitch showed to Dr. Aya how that thing works. It takes literally 3 minutes to put the iliac screw in, iliac bolt, not the screw. It uses the compression of the iliac crest. So by using that, a bolt is always stronger than a screw. And it's all performed MIS, completely MIS. So it doesn't really change anything in the equation. And that's one of the downfall. The iliac screws are very powerful screws for stability, but the problem is, to my best knowledge, almost every method that tried to do that MIS, it was so awkward, it failed. Now, like there's this famous doctor in Los Angeles in Cedar Sinai, Dr. Anand. I met him a few times in India. He's originally Indian, and when I was there, I met him. He's one of the very few people who tried that to do it MIS, and even he gave it up and so on. But our system is very well designed to exactly do that MIS. Oh, doing it open, Sonny, probably you did 30 years ago iliac screws, right?
No, we did it different. We had to use about this. This was developed by at Johns Hopkins, Johns Hopkins Hospital, and by a chief there. I think he's the Egyptian guy, but it's been popularized. Spanseller and I forgot the other guy's name, but this has been around about 15 years, and this actually revolutionized the pelvic fixation. It
Well,
is
I did that in my residency.
demanding, because there was a case where the surgeon at Hopkins was putting it in, and he got into the iliac artery, and they have to call the IR and embolize it, and stop the bleeding. So you gotta know what you're doing with this screw. You gotta have a pelvic inlet outlet views, and you gotta know exactly what you're doing and study the anatomy carefully prior to embarking on this iliac fixation.
Yeah, I mean, but I did iliac screws in my residency, so this is old enough for me to learn it in the open traditional way in my residency. But obviously, doing it MIS is the next step that we are hopefully
Right.
ushering
That'll be
in.
good.
Yeah.
MIS would be very good, because this requires lots of dissection.
In the remaining
Lower half
time,
of
Sunny,
sacrum.
in the remaining time,
Can I ask just one follow-up question about the first patient you presented?
Yeah.
So that flat back syndrome, do you think that developed because of just natural degeneration, or had you intervened with a different treatment earlier, would she
That was
not have developed that?
iatrogenic. Iatrogenic, meaning that the surgeon who operated on the patient, did a multiple surgery, did not have a really no concept of a spinal alignment and glue together. So many of these are very iatrogenic problems.
Well, flatback
Caused by the surgeon.
flatback syndrome is
Likely
not having the
neurosurgeon.
curvature after not having the curvature after the surgery. So by definition, flatback syndrome is a so-called post-surgical kind of finding. And that IOT is again unsuccessfully trying to be funny. It has nothing to do with being neurosurgeon or orthopedic.
Successful.
I'm saying
thought it
it's
was kind of
likely a
clever.
neurosurgeon, likely a neurosurgeon, because this person went back and put in a paddle. And Dr. Kim and I are one of the few people that put in paddles. So it's likely, based on deduction, a neurosurgeon.
So, but either way, it might be at times, correcting the flatback syndrome or restoring the anatomy to proper is a bigger surgery sometimes. And sometimes surgeons decide, no matter if they're a neurosurgeon or orthopedic surgeon, that risk versus benefit is not really in their hand. Imagine if that surgeon need 10 hours to do that surgery, to do the proper surgery.
So the pedicle subtraction osteotomy I did on this lady, it's kind of like my nuke. You only take it out rarely. That's my nuclear bomb, okay?
Yeah.
You wanna just use a conventional weapon as much as possible.
Yeah.
But PSO it's a nuke because it's 8-hour surgery in 80-year-old woman. Just imagine that.
Yeah,
With
and that's
foot incision about a foot deep. Okay, you don't wanna go there if you don't have to.
so either way, yeah, by definition, flatback syndrome is a iatrogenic situation, but it is not like somebody did something wrong, in my opinion, necessarily. It means just it didn't work for that patient, or the doctor decided, no, I don't want to do osteotomy on this patient because in my hand that the risks are higher than the benefit of the surgery. Now, I want to talk in the next for 10 minutes for benefit of Dr. Raouf a little about fusion versus decompression, and we can do a kind of a rapid fire things. Looking at this picture, Dr. Raouf,
Yes, sir.
would you prefer fusion or decompression?
I will prefer fusion in decompression both, sir.
Okay, so fusion. I mean, fusion almost include decompression. So not just foraminotomy, but fusion. What about you, Dr. Aya? What do you think?
I would prefer fusion
Okay.
because of that 3-4 level. There's a listhesis, there's a lot of flavum hypertrophy. So decompression there in my hands would destabilize it. So if I'm doing a 1-level fusion, I might as well just extend it down to that lower level if that's also symptomatic.
Okay. So Sunny, what do you think?
I'll just do a fusion at 3-4.
What are the symptoms?
That's the point. This is a trick question, everybody. Okay.
Oh, that's what I always ask.
So see, this is a trick question. We never make a decision based on surgery, just based on a picture.
How about X-stop? With you guys, the interspinal process.
What are the symptoms? Now, imagine if this patient has only L4 or L5 radiculopathy that says, doctor, this is leg pain is the only thing bothering me. In reality, it's always combination. So generally, if the radiculopathy and claudication is the main symptoms, meaning that compression of a cauda equina or nerves are causing the symptoms, I think the compression is still a good option, no matter what the picture looked like. I had the best story I got. It was a patient with a horrendous scoliosis and had L5 radiculopathy. And I did a L5S1 foraminotomy. That patient, I watched him for 4 years before he moved somewhere else. He never needed that scoliosis treatment. Okay? So we have to get...
And also, I mean, you taught me. I mean, I always ask them about neuraxial back pain. So I always try SI joint injection first, because sometimes the SI joint that's really their back. That's their only problem.
And
Honestly, sometimes patients, even with if it's severe stenosis, they usually have neurogenic claudication, I've noticed. But if it's moderate stenosis, sometimes they don't report that. It's just like they have back pain.
so the rate of sacroiliac joint being the problem is Dr. Aya, you and I, we have talked about that, for benefit of Dr. Raouf. And you get 100 patient, first time, no prior surgery. What does statistics say? What percentage of that is sacroiliac joint? Knowing
It's
nothing
usually
about that except that they have first time lower back pain.
about 30%.
It's to about 23%, according to literature. Now, let's say take the same patient, you do, but they had prior spinal fusion, especially lower spinal fusion.
Oh,
You get
much
100
higher.
patients with lower spinal fusion, and now they have still back pain. What's that percentage of that being sacroiliac joint in that group of patients?
30%.
40.
43%.
I'd say 40.
43%. These studies are done. Okay, we don't have to invent that. We just have to go read the papers. So, in a native, no prior surgery, 23%. In the people with prior, especially lower back fusion, 43% of them, now the pain is sacroiliac joint. What that means is, don't look at the picture and say what you are going to do as a young surgeon. Literally let the patient point to where the finger is, with the finger where the pain is. And if they put the finger on the sacroiliac joint, that's called 14 test. Think about this. Include that always in your initial evaluation. That's the first message I want you to get out of this. The second message I want you to get out of it is that even though the traditional sacroiliac provocation test is very awkward, time-consuming, and so on, learn the so-called rapid sacroiliac joint combined provocation test. It takes only less than a minute, and it gives you a lot of information. And sometimes when you just ask them to put their ankle on the knee, they already say, "Oh, but my hip is killing me. I cannot do that." Here, you got it. You don't even have to work hard to include that in your differential diagnosis. And then I think what's very important, distinguish between axial pain, radiculopathy, and claudication. These are three things that you have to distinguish and involve in your differential diagnosis. Scott, you see this patient all the time. Do you want to describe in your practice claudication, axial pain, radiculopathy? What is your protocol? Everybody develop its own protocol, even if you don't write it down on a piece of paper. What is your path from there to offer
So
them?
I categorize patients. I ask them to. I try to categorize their pain into two main types of pain: neuropathic versus mechanical. If it's more mechanical pain, then I ask them, in a patient like this, I'd ask them about their ability to walk, if they're able to walk a distance without stopping to rest, if they have spinal stenosis on the MRI, I will just ask them outright. I'll say, if you are walking a distance, do you have to stop and rest because your back and your legs get achy and tired? And a lot of times they say yes. Sometimes it surprises me. They're like, no, I can walk 2 miles, no problem. So then that puts me in a mechanical pain pathway to think about, is it due to spinal stenosis? If they have foraminal stenosis and they say they have pain in a specific dermatome, I call that radicular pain. And I'll start with injections, but then potentially refer to surgery if necessary. If it's pain that's in the buttock all the time and they have positive Faber, then I look at SI joint. If it's purely neuropathic, burning, tingling, numbness, that's in my opinion nerves that are damaged, and often, and it's not dependent on position. Then I go down a pathway of treating with, like thinking about spinal cord stimulation, because really it's not a nerve that can be decompressed and result in pain relief. It's just a nerve that's damaged. It's going to be sending a pain signal all the time.
As you described, Scott, there's truly a huge difference between what we call a visceral pain and neuropathic pain. But when we look into that, any kind of compression or any kind of compression-based pain, if you give it enough time, will become neuropathic with time.
Mm-hmm.
What that means, and to understand that, Dr. Aya and Dr. Raouf, is to have to understand what neuropathic pain really is. What is the definition of neuropathic pain? What is neuropathic pain?
Due to nerve irritation, compression, a pain going to the leg, like a tingling sensation or a current-like sensation.
No, I think we can do better definition than that these days. So, Scott, first, why don't you describe what is the characteristic of neuropathic pain before we talk about how a compression of the nerve will end up becoming a neuropathic pain eventually. What is the characteristic of neuropathic pain?
So the pain descriptors are typically burning, tingling, numbness, stabbing.
And combination of all of it.
Often all of it. And then
yes.
you contrast that. Sometimes it's easier to contrast and say, if it's more like a toothache, then that's bones rubbing together. That's certainly mechanical pain. I would say most of the time, if that neuropathic pain changes with position, then it's often more to nerve root compression or because loading and unloading the spine can cause that. But also neuropathic pain encompasses damage to peripheral nerves or small fiber nerves, such as from chemotherapy, diabetic peripheral neuropathy.
Lots of
we call idiopathic neuropathy, but if you look carefully, and this is out of the purview of spine surgeons, but if you look carefully, about 40% of patients who finally get a formal diagnosis of diabetes already have neuropathy. So there's probably pre-diabetic peripheral neuropathy that's encompassed as well. And that's a metabolic issue or some chemical damage to nerves. But the symptoms are the similar. The description of the pain is the same.
So one of the basic, and that I want to usher it in this way. One of the main part of that neuropathic pain is that something that should feel as touch, they feel it as pain,
allodynia,
burning, allodynia, dysesthesia, paresthesia, and so on.
Hyperesthesia. Yeah, the dysesthesia, that's a different one too, because they'll say, oh, it's not painful. It's just, but a dysesthesia, people are really happy if you can actually articulate that a non-painful stimulus that is not pleasant is also like, that's valid. That's like, that's because.
Let me tell you that how the molecular and pathologic base of neuropathic pain is. Imagine there are 100 houses here. These 100 houses, they send a telephone line to one place that get together and goes to the telephone company. That when I call the telephone company, they know it's Abbasi. But when my neighbor calls, they know it is my neighbor, not Abbasi. Now in our body, we have receptors for pain, for temperature, for deep touch, for superficial touch, for stretching of the muscle, for stretching of the tendon, for pressure on the tendon, and so on. And they all come together in the peripheral nerve and go to the nerve root, then go to the spine. When you push on those nerve structure, let's say at the nerve root level, long enough, all of a sudden, Abbasi's telephone line get mingled, and then when telephone company, they get a call, they think it's Abbasi, but it's actually my neighbor because the fiber literally mingled together. The myelinization, because of the pressure, goes away. The nerve get damaged. The signal of one receptor get carried by the other receptor, like allodynia and so on. Okay? Now, this can happen by long-standing pressure, or it can happen because diabetes, the vessels go dead. There's no enough blood supply to the nerve root or nerves, and then it's a chemical hypoxic injury. Or with the chemotherapy, it's literally a demyelinization and a actual neuronal injury that the signal of one kind of entity, one quality, get carried by the other one. And guess what? Most of that, the nerve fibers are usually the first to be damaged, meaning that If everything is damaged, lots of pain, it's other signal like touch, we feel the touch as pain. And we feel the temperature as pain or as burning, and so on and so forth. So on the molecular pathological level, it is practically the intermingling of different entities of signal that can come from chemotherapeutic, from diabetes, from rheumatoid thing, but mostly what we encounter in our field from long-standing pressure on the nerve itself that caused the damage. Now, coming back to that, then we have, let's say that is a different entity. Let's talk about now mechanical problem. It's either claudication or direct pressure on the nerve root. And the difference between claudication and direct pressure on the nerve root is that claudication is in the L2 and below. It pushes on lots of nerves within the confine of the spinal canal, whereas radiculopathy is literally in the lateral recess and foramen is usually 1 or 2 segments, but the lateral recess or foramen. And then what as well I think is very different, and then you have the so-called axial pain. So in my opinion, axial pain is rarely respond to decompression alone. Sometimes it can, but claudication and radiculopathy, they are a good candidate always for focal decompression, whereas axial pain, and I see them all the time. Another surgeon that did the first foraminotomy, the second discectomy, and the third foraminotomy, got the CSF leak and everything, and wait until patient is neuropathic before say, okay, you need a fusion. We shouldn't wait until they develop neuropathic pain, the nerve is completely damaged, before we offer them fusion. Now, considering risk versus benefit is in open surgery so high, I understand why other surgeons are doing that. But in our protocol, Dr. Raouf, patient has sting radiculopathy and the claudication is, let's say, 70-80% of the symptoms. Definitely foraminotomy and decompression is the first main of the treatment. If the axial pain is the mainstay of the treatment, is the main symptoms, fusion is, in my opinion, more appropriate. If it is 50-50, then it's a more in-depth conversation. Okay? Is it like what Dr. Kim was describing? How is it when you lay down? Does the pain go away? When you sit down, does the pain go away? Then you do a lot more work with them with physical therapy to strengthen paraspinal muscle to support them that their back can carry more when they stand up and so on. But somebody comes and say, doctor, I have no leg pain. My back is killing me and I'm going to kill myself if you don't fix me. I get those patients. Do you know what half of our colleagues do? They say, no radiculopathy, only axial pain, no surgery at all. Get out of my office. If you're going to go kill yourself, go kill yourself. I don't care. Fusion doesn't work because fusion doesn't work in their hand because they do an 8-hour surgery, cause 25% risk of infection. They do a 7-hour surgery for a 1-level fusion. Then fusion doesn't work.
Yes, sir.
And you and I, we know them, right?
Yes.
There are sometimes people who criticize us. They say that we should do only open surgery where they need it for 1-level fusion, 5-7-hour surgery. So coming back to our protocols.
And just to speak on that, some of the oldest literature that we have in orthopedics show that fusion in the setting of mechanical axial back pain is actually one of the most successful surgeries. It's right up there with ACDF, but the caveat is mechanical axial back pain.
And then we have as well that multi-center European study that says fusion helps only 37% of the patient. 37% of the patient. Sonny, imagine if 2/3 of our patient wouldn't get better with our surgery. Imagine what world we live in. But that's the data. If you just use the axial pain as indicator, fusion in the traditional sense where what's published, but the problem is people who publish that they're academic. They weren't in private practice. Private practice people don't publish their paper, but private practice people couldn't survive if 2/3 of our patients don't get better. We would lose our license in like 1 year. If 2/3 of our patients would be same or worse after our surgery, right? Sonny, you know that's not our result. No, but that's still the paper. Multicenter study that only 37% of the patient improve with axial pain after fusion. I think there are so many different flaws in that study that I cannot even start. But coming back to our protocols, if axial pain is the main symptoms, I think fusion is better option. Obviously, there are some other criteria like spondylolisthesis, especially mobile spondylolisthesis, is a very important factor. Now, and then the question is direct decompression or physiologic decompression with OLEF, what we call, other people call indirect decompression. Sonny, last question. What has been your result regarding direct versus indirect decompression with OLEF? What has been your experience so far?
I think my experience is that indirect decompression is far superior to the direct decompression because I've done first 30 years, I've done lots of direct decompressions. And there's lots of complications, CSF leak, destabilizing the segment, etc. And indirect decompression, I think I may be 1 or 2 failures. And I never had to take anybody back. I mean, once you achieve the solid fusion, it stops the motion, even though there's some small amount of residual stenosis left, patient's symptoms go away. You know, the motion, if you eliminate the motion, so you gotta achieve a solid fusion. If you don't achieve a solid fusion, the symptoms will come back.
Yes.
But if you achieve a solid fusion with indirect decompression, 99% of time it works.
Yes, and your number is very accurate, Sunny. But this is the data based on 2,150 cases I have done with OLEF, is that in some cases, if the patient has osteogenic stenosis, sometimes that's why we always get a CAT scan, Dr. Raif. All our patients get a CAT scan within 6 months before the surgery.
Yes, sir.
If they have osteogenic stenosis, usually we do consider direct decompression.
Let me tell you about, sorry for the interruption, but the diagnosis, indirect decompression works great, is something that you will never imagine this will work.
Yes.
It works great for recurrent disc herniation, which is big unsolved problem in spine surgery. It works great for the synovial cyst, Scott. You don't have to remove the synovial cyst. You put that big cage in there, open up the canal, synovial cyst dissolves away. So these are the surprising diagnoses where indirect decompression works.
Yes.
Obviously, scoliosis and all that stuff.
Number one, if there is acute progressive deficit in our protocol, we still recommend direct decompression. Like somebody has a broken bone and a piece of bone is pushing on the spine. If there's acute compression with neurologic deficit, direct decompression, because direct decompression is the most reliable way to make sure I cut the bone, the spine is free, and so on. So, but that is so rare. That's mostly trauma. Number two, if there is patient has osteogenic stenosis, and on top of that, this would be a factor by itself, but it's becoming more relative after I'm analyzing my data. Or if the patient lay down, but the pain's still there. When the patient lay down, sit down, pain's still there, meaning that that compression is bad enough that even in the relaxed position causing pressure on the nerve. But if the patient sits down, lay down, pain goes away, and there is not a piece of chunk of bone in the spinal canal, but physiologic decompression, I don't call it indirect anymore. I'm rephrasing, we are trying to change the name. And so-called physiologic decompression is very, very powerful. So considering this, there are certain patients I decide first to do decompression with laminotomy, not laminectomy, laminotomy. The difference is that We go unilaterally, unroof the lamina and so on. And there are certain patients that I still do. Like a few weeks ago, I did a patient who had in thoracic region myelopathy. I did a decompression and fusion at the same time. But in vast amount of patients that I have done over 2,100 indirect decompression with OLEF, in 13 cases, I had to go back and do a decompression later. So in 2,150 cases, I have done 13 patients that I thought indirect decompression is enough, but it wasn't. So that makes that rate really very, very low. But what you need to know, 5 of those patients, 5 of those 13, they had a trauma involved. What that means is that I did a decompression, 5 of those patients had a trauma, fell, motor vehicle accident, and so on. In 2 of them, actually, the cage moved, and so on and so forth. And then that was the reason. But so 7 of them with no identifying factor, direct decompression was later on required because physiologic decompression initially wasn't enough. Now, do you want to calculate what that rate is? Actually, the rate is much below 1%, way below 1%. That rate is like 0.34%. And I think that is a really good statistic on our side, Sunny, that physiologic decompression is very powerful if you follow those steps. So, Dr. Rauf, you have to understand if the pain is mostly axial,
Yes,
or
sir.
radiculopathic or claudication, if it's neuropathic or not. If it does get better with laying down and sitting down and lying down, and everybody get a CAT scan to make sure there's not an osteogenic stenosis. These are the protocols that I think is important for you to internalize. So it is 11:17. I think we went way over our time, but I think it was important for you, Dr. Rauf, to be here and understand our protocols. And certainly we have a lot of variation in different. Dr. Kim does a lot of scoliosis, big cases, and so on, and you can learn a lot from him. And there are lots of subtleties to that, but that's beyond the scope of our case conference. Okay, any final comments or questions?
No, thank you very much. It was very
Okay.
informative.
Okay, thank you, everybody, then. You have a good rest of the weekend.
Thank you.
Okay,
Thank you, Dr.
Bye-bye.
Abbasi.
Bye-bye.
Bye-bye.
bye.